Good evening, one and all. This is Dr. Kishore from Hyderabad. We welcome all the participants on behalf of Sahasra ENT Foundation. It gives us a great pleasure to introduce you Mrs. Hina Baxi Deshmukh, who is a rhinoplasty surgeon, consultant ENT and rhinoplasty surgeon from Indore, who is the managing director for Asian Center for Ear, Nose and Throat. She got her post-graduation from KLE Belgaum, following which she did a fellowship under Dr. Narayan Janikaram in skull-base surgery, following which she did a fellowship under Dr. Virendra Gaisas, and she got trained under Dr. Gubish from Germany in rhinoplasty. And she is last class we discussed about relevant anatomy for rhinoplasty, and which went on really well. And we are happy to go ahead with the next topic, that is preoperative evaluation for rhinoplasty. And we welcome you, Dr. Hina, ma'am.
Thank you, Kishore, for the introduction. Again, words wouldn't be enough to thank you guys for coming up with this platform where all of us can, share our ideas regarding the expertise that we practice in. So today, going on with the second lecture of this Rhinoplasty Masterclass series, we'll be discussing about the preoperative evaluation in rhinoplasty. So I've tried to keep this topic very practically oriented, something that one has to, practice in their own clinics, some easy and practical points that have to be covered, because theoretically there is there are many things, many concepts and many things to measure in a rhinoplasty patient, but practically what all is possible, I've tried to cover here. So So coming to the preoperative analysis, preoperative analysis is just not looking at the face of the patient, but is an overall analysis. So you look at the psychological aspects, you take an overall idea about how psychologically stable and clear the patient is about their goals, what they want to achieve with this surgery. Then you go to the aesthetics of the whole face, the whole personality. And then the most important thing as we ENT surgeons is the function of the nose. So all this together will be included in your preoperative analysis for your rhinoplasty patient when you're planning for surgery. So I always focus on this point a lot, that you have to evaluate the patient as a whole, not the face and not just the nose. So you look at the personality, look at the basic body language, how it looks, whether they are confident enough, who is accompanying the patient, whether the patient has come alone or is being accompanied by a friend or a family member. So that means that the patient is quite comfortable discussing, their issues with their nose amongst the close people that he has around him. So that kind of gives you an idea that the patient is a little bit more confident, not very jittery and not very indecisive. So then look at the body posture, the hand movements and all. If they look very clumsy and jittery, you should get an idea that there is something wrong. There is some kind of lack of confidence in this patient already. Then look at the basic ethnicity. You should be able to guess whether the patient belongs to the north part of the country, south part of the country, east or west. And accordingly, one has to set their goals realistically, as in what can be delivered and what cannot be delivered. So because as I explained in my last lecture, that the skin type, the framework of the nose, the septum material, the cartilage quality, it all differs as you go from north to south. And that sometimes also limits the kind of results that you can deliver. So one has to keep ethnicity always in mind. Another thing that I always consider is the height of the patient. So if the patient is very tall and you give such kind of patients, a very droopy kind of nose, it makes the whole face even more longer, and it is not very aesthetically pleasing. Whereas little upturned nose is considered to be better when you're dealing with short-heighted patients. So you should also look at the height of the patient. Then the skin type also I have mentioned in my previous talk, that the skin type has to be kept in mind, because in thick skin patients, again, your hands are tight. You might not be able to deliver the best of the results, or you have to keep the patient's expectations very realistic, so as what you can give and what you cannot. Because if in thick skin patients they are expecting a very sharp kind of tip, it is kind of difficult to give those kind of results, those Caucasian kind of features. So you have to ground your patient's expectations. And then you come down to the facial analysis, which we'll be talking about in detail. So like I explained, the psychological analysis is very important. You should take a thorough history of the patient, as in if there has been any trauma or any previous surgeries. Always focus on multiple consultations. Of course, you should give a clear idea of your surgical plan once you're sure that the patient needs a rhinoplasty and you can deliver what he wants. But I would still suggest that you should be able to create a bond with your patient, because this is ultimately a change in his or her face. So then you need to be confident that you've chosen the right patient for your series, and the patient needs to be confident that you are the right surgeon to deliver what he wants. The patient should be clearly able, if you are dealing with a psychologically stable patient, the patient must be clearly able to define the dislikes of his nose. For example, what I consider as a simple formula is that the patient should be able to tell me 3 things that they dislike in their nose. Probably they don't like, they don't feel that the nose is straight. Maybe they feel that the tip is too broad. Maybe they feel that there is some kind of a nostril asymmetry. In my head, I try to calculate whether I will be able to correct these 3 concerns that he has or not. If these things match, then yes, this is a good candidate of rhinoplasty. In case a patient brings in pictures of some actresses or actors, or some idealistic nose that they desire their nose to be that way, it sometimes becomes, it should be an alarming sign actually, and one should really consider 2-3 more consultations, and you should really try to find out the motivation behind the patient's will to get a surgery. You should always be aware of body dysmorphic disorder. So how to find out that whether this patient, because of course anybody who comes to get a rhinoplasty done doesn't like their nose, doesn't like their facial features. But in case you feel while conversing that maybe the patient is pointing out to 2 or more facial features, for example, you say, oh, your hair looks little flimsy, or there's not much volume, maybe we can do, have you taken some treatment for it? They will start criticizing their body part. You talk about their lips, they will start criticizing that as well. So if they are criticizing more than 2 or 3 body parts of their own, then maybe you should get this sign that you might be dealing with a body dysmorphic disorder. Sometimes these patients try to project their personal problems on their facial features. For example, they would say that when I work in the office, I feel that people are staring at me because of my nose. I don't have many friends because of my nose, or probably I was in a relationship and it went wrong because of my nose, or because of my because I think I feel I look ugly, or probably that person has said that I look ugly. So these kind of things should always alarm you for to detect a body dysmorphic disorder, and these kind of patients need a thorough psychological consultation with your psychiatrist colleagues, and after being absolutely thoroughly sure with proper consent, maybe you can touch these patients, but I would still be scared. And next comes the photographic analysis. So one must be aware of what kind of a photography setup you need to get pictures of excellent quality, wherein you can analyze these pictures for facial aesthetics. What I have with me is a DSLR camera. A 50 mm or a 35 mm portrait lens is good enough. The ideal light arrangement should be 2 lights of equal intensity positioned at 45 degrees from the subject camera axis, and there should be at least a 6 feet distance between the photographer and the subject. The background always has to be uniform, so that you can compare your pre and post-op results, and the views have to be standardized, like we know the frontal view, the profile view, oblique view and the base view, and sometimes you also take a sky view. Another thing that practically sometimes it is not possible, to carry your DSLR camera everywhere. Sometimes we don't operate in our own setups, we go to multiple places. So it's not possible to carry your instruments and headlight and loops and, camera and everything. So how to take better pictures with a mobile phone? So here are two pictures that you can see. So on the left is a picture which is taken too close to the patient. So probably somebody had sent me this picture. This is the same person on the left and the right, but you can see that the central features become very magnified, certainly they look magnified, and the nose looks bigger and wider. And there is some kind of a distortion also. And of course, the patient is not standing straight as well. So even on a mobile, you can take a good picture, which is probably on the right. This has also not been taken by me. There are some shadows. But it is still decent. There is no fisheye effect, which I was describing before. So this you can eliminate only by creating a distance of more than 4 feet, 5 feet, so that this fisheye effect is nullified. So what do you look at now? Coming to the facial analysis or the facial aesthetic analysis. Once the patient is sitting in front of you, what all do you observe? Or probably retrospectively, after taking the pictures, what all do you see on the photos? So we'll divide it according to the views. This we are dealing with the frontal view first, which is the and I'll be describing each feature subsequently. So first you look at the facial proportions, whether the face is fairly in proportion, whether there is any shortening of the middle third of the face, or the forehead is big. So all those things you should see. Then look at the skin type and quality, whether it's thick, thin, sebaceous, oily, what kind of skin you're dealing with. Look for symmetry or nasal deviation. If there is any facial asymmetry or a gross nasal deviation, it can be very well appreciated on the frontal view. Look for the dorsal aesthetic line. So if you have good lighting and a good photography setup, definitely you will be able to see dorsal aesthetic lines. In this case, you can see that they're slightly broken because of some deviation. Now, coming to the parts of the nose, like we know from the anatomy lecture that the nose is divided into 3 parts. The uppermost part is the bony vault, then comes the middle vault, which is the cartilaginous part, then comes the tip. So all these 3 things should be analyzed from top to bottom. On the bottom part, you can also see the alar rims, whether they are uniform, what kind of configuration they are in. Look at the alar base and the upper lip. So the facial proportions, we all know that if we go from top to bottom, it is divided into equal 1/3. The topmost part is between the hairline and the glabella. Hairline, you can we know that the hairline starts at the top of the forehead, and the glabella is the point where the 2 eyebrows meet. And in Indian culture, this is where the bindi is put, or the kumkum is put. And so this is the upper 1/3 of the face. Then the middle 1/3 starts from the glabella and the subnasal. Subnasal is the lowest part of the nose, where the columella attaches to the philtrum. And the lower 1/3 starts from the subnasal to the chin, or the pugnion, that is called. So all these 3 should be equally divided into 1/3. And if we see horizontally, the face is divided into equal 1/5. It starts at the side of the hairline till the lateral canthus, and then the medial canthus, and the intercanthal distance, and so forth. So her face looks this is actually my sister's picture, and her face looks fairly proportionate to me. Next point is the skin. So skin, we know that as we go from north to south, there are certain ethnic variations that we see in the skin type. So in the north, you would see very thin, light-skinned people, whereas in the south parts, the typical Dravidian population, you can see a thick, dark, sebaceous skin. This is one of the major determinants of the outcome, because if you do any minor tip grafting or minor techniques to augment the dorsum, it might not be very appreciable if the skin is thick. Whereas in a thin skin, even the smallest of grafts, even a smallest of irregularity can be appreciated post-op. So your techniques, your type of grafts, it all matters on what kind of skin you're dealing with. Thick skin problems are, of course, poor contour definition. There is a much more prolonged edema, inflammation is prolonged, and aesthetics are not that much favorable. Next comes the symmetry and nasal deviation. So there's this simple mobile app that I have used. This can roughly give you an idea of how much of asymmetry there is in the face. So it basically replicates one half of the face. So if we take the left part of the face, this picture that you can see on the top left, this is how she would look if we make both the sides according to the left part of her face. And if we do it according to the right, so that means that they were not equal, right? There was some kind of a mild facial asymmetry. So literature says that almost 95% people have some kind of a minor facial asymmetry. In some patients, it is quite apparent. We can see it very clearly and grossly. And in such cases, one has to discuss again the realistic goals, and if there is any role of adjuvant procedures, that also has to be discussed. So in this patient, as you can see, if I try to draw a line from the midline in accordance with his forehead and the glabella, so there is a huge difference of the in the skeleton of the left side and the right side. So one has to recognize and discuss the limitations of surgery pre-operatively with the patient, and then if there is any role of adjuvant procedures, for example, if you want to augment this flat maxilla or maybe put some fillers to camouflage the whole facial asymmetry, that can be done. Also, once you straighten this kind of a nose, patient will always feel that there is some remnant deviation still there. So that that has to be discussed pre-operatively for sure. And then next comes the dorsal aesthetic lines. So dorsal aesthetic lines are another is a very important aesthetic feature that we see on see pre-operatively. So what are these dorsal aesthetic lines? They're basically an interplay of shadows and light reflexes. And it all depends on the dorsal integrity and the dorsal smoothness. So the smoother the dorsum is, the more regular these lines will be. And if there is any deviation, you can also see that these lines will be seen as crooked or broken. So these are very important, especially in the people who are working in front of the camera. So they usually desire these sharp lines so that it looks much better on screen. So here you can see that the subject that I have chosen, she has little broken lines. That is because she has a hump. You'll see subsequently in the lateral view that she has a small hump here in the just at the junction of the bony and the cartilaginous wall. And there is also a slight deviation of the nose. Coming to the analysis of the three walls, the first one is the bony wall. So what do you look for in this bony wall? You look for the base bony width. Now base bony width is the widest part of the bony wall at the level of the maxilla, where it attaches to the maxilla. So that is the base of the nose here somewhere. So this should be approximately 70 to 80% of the alar base width, and any deviations and asymmetry in this area should be noted, and it has to be dealt with maybe a bony remodeling or osteotomies. So these are the two nasal bones that we can see. The left one seems to be flatter and a little bit wider. So like I explained, in this patient, you can see that the base bony width is quite wide. And instead of being 70 to 80% of the alar base width, it is almost equivalent to the alar base width. So definitely he will be quite benefited by osteotomies, which will narrow his base bony width and give him a much better aesthetics. Coming to the middle vault evaluation, middle vault is of course formed by the paired apolateral cartilages and the cartilaginous septum. So here again, you can see that there is some kind of inequality. So in this patient, you can see that there is a gross deviation in the middle wall. That is because of the internal septal deviation, which is pushing the right upper lateral cartilage to the right. In this patient, sorry, you can see that there is some kind of a depression in the middle wall, probably an leading to an inverted V deformity. So this patient will need a reconstruction in this area, probably a total septal reconstruction, which will reinforce this cartilaginous wall. Next is the nasal tip, the lower third. The tip is ideally supposed to be in a triangular, inverted triangular configuration, should be well defined. The infratip lobule midpoint should be in the middle. Like you can see in this subject, it is right in the middle, coincides with the philtrum and the bow and arrow, Cupid's bow also. Whereas in these pictures, you can see that this patient on the left has a very boxy wide tip, and even the infratip lobule is not very well defined. He has a retracted columella, while this young girl has a deviated infralobular tip point, and there is some kind of bifidity as well. Yeah. Next comes the alar rim. So alar rim configuration should be gull in flight like you can see in this line diagram that I have drawn. This is the ideal configuration. Any retraction, collapse, notching, or any kind of parenthesis deformity should be noted. For example, in these pictures, you can see that this patient has kind of a parenthesis deformity. This is usually contributed by a cephalic rotation, extracephalic rotation of the lower lateral cartilages, leading to such kind of a notched appearance. Whereas here you can see quite a flat alar rim configuration. Next comes the alar base. Alar base should be approximately coinciding with the distance, the intercanthal distance, and it should be 70% of the nasal height. Now, how do we look for alar flaring? So you ask the patient to smile. Any hyperdynamic movement which leads to flaring of the alar more than the intercanthal distance has to be addressed. Also, one must look for larger nostril sizes, alar base or nostril asymmetries. So this is how you ask your patient to smile and look for alar flaring. If it is too much, then one has to address this by method of alloplasty or sil resection. So these are examples of wide alar base. On the left, you can see this lady has a little irregular alar rim. Sorry. Yeah. So there are some irregularities in the alar rim area. And also it is quite wide. The alar base is quite wide, similar to this young gentleman who has quite a ideal intercanthal distance. But if you see, if you look at his alar base, that seems to be quite wide. Next is one should also look for an overactivity of the depressor septi muscle. So you ask your patient to smile, and if you see, if you notice that the nasal tip is going down significantly, so in this patient is almost touching the upper lip border. So this is indicative of overactivity of the depressor septi muscle, and this has to be addressed intraoperatively. Few fibers which are connected to the caudal border of the septum can probably be dissected off, and one can get an ideal result by and prevent this tiptosis phenomena. Now coming to the lateral view, what all do we have to see is the nasofrontal, starting from the top to bottom, the nasofrontal angle, that is the radix, the tip projection, alar columella relationship, lip chin relationship, the periapical hypoplasia in this area somewhere, the nasal length, dorsum and supratip, and the tip rotation. All these things have to be noticed in the lateral view. So coming to the lateral view, practically, these are the two most important angles that we analyze. So first is the nasofrontal angle. These are slightly different in when we compare male and female aesthetics. So in males, the ideal nasofrontal angle would be somewhere around 115 degrees, whereas in females, it is slightly more obtuse to about 120, 125 degrees. The nasolabial angle, as you can see in this picture, again in males, it is around ideally 90 degrees, and in females a slightly rotated nose, that is a nasolabial angle of about 100 to 105 degrees, is considered to be ideal. So here her nasofrontal angle, as you can see, probably she can do with some kind of augmentation in the radix area. You can see that there is some depression here in this area. Next is the critical starting point of the nose. So critical starting point of the nose is exactly the point where the dorsum starts to project. So in ideal Caucasian aesthetics, it is defined as the point coinciding with the upper eyelid crease. So you can see in this diagram on the left, the ideal critical starting point of the nose coincides with the upper eyelid crease. Whereas in Indian aesthetics, it is slightly lower, slightly 2 to 3 millimeters lower. And this is how you decide how much you need to augment the radix, the dorsum, and adjust the tip accordingly. Now here you can see this lady on the left has a very low critical starting point of the nose, whereas here on the right, he has a very high critical starting point of the nose. So the lady on the left needs dorsal augmentation, whereas the boy on the right would do very well with a reduction rhinoplasty. Next comes the nasal length, the dorsum, and the supratech. So the nasal length should ideally be 2/3 of the mid-facial height. So the mid-facial height, as you know, is from the glabella to the stomion. So this height, the nasal length has to be 2/3 of this mid-facial height. The supratip area, ideally in females, little supratip curvature is ideally aesthetic, and it looks quite pleasant in females, whereas in males, a fuller profile is much more preferred. Here you can also notice the small hump that that is present at the junction of the bony and the cartilaginous wall. So now these are examples of some overprojected dorsum and a saddle nose. So this girl has a both bony and cartilaginous hump here, and her nasal length is also quite much. Whereas on the right, you can see that this is a saddle nose concavity, saddle nose deformity. And next point is the tip projection. Ideally, if you draw a line, a vertical line from the upper lip, 50 to 60% of the tip is expected to lie anterior to this vertical line, and this is a proper projection of the tip. Anything more is called as an overprojected tip, and anything less is called as a underprojected tip. So here is another example where if you draw a line from the upper lip and extend it upwards, you will see that hardly 30% of the tip is lying in front of this line, and it is a kind of a binder's nose syndrome. Whereas on the right, you can see an over-projected tip. Most of the tip is lying in front of the upper lip, anterior-most point of the upper lip. Next is tip rotation. This is determined by the nasolabial angle, which I had described earlier. So how do we define this angle? This angle is between the line drawn through the midpoint of the nostril aperture and a line drawn perpendicular to the Frankfurt horizontal plane while intersecting the subnasal. This angle, if it has to be corrected, the septal extension graft plays a very important role, as well as the tongue in groove suturing methods, which we'll be discussing again when we discuss the surgical parts of rhinoplasty. So this is an angle of, this is an example on the left of an acute nasolabial angle, whereas on the right, it's quite open and quite over-rotated, in fact. So these are two extreme examples. Next to see is the alar columellar relationship. So usually a 2 to 3 millimeter columellar show below the alar rim border is considered to be aesthetic. Anything more is an extracolumellar show, and anything less is an underprojected case. So yeah. So this is here you can see now there are two scenarios. There can be either a hanging columella or there can be a retracted alar rim, and this also has to be identified because the maneuvers to correct both are slightly different. Next to notice is the periapical hypoplasia or the premaxillar deficits. So on the left, this candidate doesn't have any kind of a periapical hypoplasia, whereas here you can appreciate that the alar base insertion is quite posterior when you compare to the lip configuration. And here is where you are supposed to notice a periapical hypoplasia or a premaxillar deficit. Usually in patients with cleft palate and binder syndrome, or any other syndromic patients usually have this associated periapical hypoplasia. Even in severe facial asymmetries, one notices such kind of deficits. And this has to be corrected either by augmentation in this area by free dice cartilage or a solid rib cartilage, depending on the degree of the deficit. One should also notice the lip-chin relationship. So a vertical line drawn from the half distance point of the ideal nasal length and tangential to the upper lip vermilion anteromost point should be drawn. In this case, on the left, you can see an under-projected tip, whereas on the right, you can see an over-projected tip, chin, sorry. Now coming to the base view, there are 5 things that you should see. First is the nasal projection, then the nostril symmetry, columella configuration, the alar flaring and alar base. Coming to the nasal projection, so the nasal projection, this configuration should ideally be triangular. One has to notice triangularity at the base, and 2:1 columella-lobular ratio. So the columella should be around 2 parts, whereas the lobule part should be 1 part. Next comes the nostrils. The nostril shape should ideally be teardrop shape. There should be symmetry. So in this case, you can see there's slight asymmetry, the left one being smaller and slit-like, whereas the right one looks quite ideal. If the alar rims are seen to be concave, that indicates pinching of the alar rims. And this has to be augmented by either alar rim grafting or articulated alar rim grafts. Whereas any convexity or thickness has to be again addressed by some kind of a overlap technique, cut and overlap technique. So here you can see that on the alar base, this particular gentleman lacks triangularity. There is bulbousness of the tip. You can also see a caudal septal deviation, a gross caudal septal deviation. The nostrils are asymmetric. Here you can see this lady has more round configuration of her nostrils, and there is some kind of irregularity at the alar rim area. Here again, you can see some kind of notching in the soft triangle area, a bifidity at the columella, some kind of nostril asymmetry because of deviation of the septum. The foot plates seem to be quite wide and displaced, so this needs to be addressed as well to create a tear shape configuration of the nostrils. Here on the right, again, there's a major caudal septal deviation pushing the sill area, causing some kind of a sill asymmetry. Also in the base view, you can very well appreciate on the right side that there is a gross facial asymmetry as well. You can see that the left side of the face is much more fuller, whereas the right side of the face is much more flatter. The upper lip configuration also differs due to the facial asymmetry because the underlying skeleton itself is asymmetric. So in such kind of patients, you should pre-operatively assess all these things and discuss the same with the patient. Next is at the base view is the alar base and flaring. Alar flare is defined as the greatest width of the alar. The convexity should not increase more than 2 to 3 millimeter lateral to the alar facial crease. So here you can see this is the alar facial crease here. I hope you are able to see my pointer. So this is the alar facial crease. Anything beyond 2 to 3 millimeter beyond this alar facial crease would be considered as alar flaring, and one has to consider Rhinoplasty in that case. Next important view, especially in cases with deviated noses, is the sky view or the bird eye view. So this picture at the bottom that you can see is a bird eye view. So once you see from the front, you can see that there is some kind of a deflection, deviation, but it is much more well appreciated. Sorry. When you see this view, this bird's eye view, you can see all these irregularities, you can see the bony deviation, you can see the cartilaginous deviation, and also irregularities in the tip. So this is also an important view that one must always take pre-operatively. Next is the oblique view. So oblique view mainly adds on to all the findings that we have noted in the other views. And it is mainly to catch some kind of dorsal irregularities, minor hump, or minor concavities or depressions that we can see on the dorsum. So any examination is incomplete without the method of palpation. So once you have done your thorough observation of the patient and the patient's photos, it is also important to feel the nose and find out more about the underlying anatomy. So a thorough nasal examination should be done. One must palpate from top to bottom the bony side walls, the dorsal irregularities, the strength of the cartilages, septal support, and the anterior nasal spine. You just take two fingers and just try to palpate the anterior nasal spine, which is just posterior to the caudal septum, the posterior limit of the caudal septum. And the strength of the cartilages also, you can just simply pinch this area and just have an idea about the strength of the lower lateral cartilages. One must also perform a Cottel's test or a Cottel's maneuver, which I'll be describing. Another important thing in the palpation is the tip recoil. So just press the tip of the patient's nose and look for septal support. So in case there is a previous septal surgery or there has been a history of septal hematoma or abscess, the patient's septal cartilage would mostly be resolved, or probably it will not be there. So support to this lower part of the cartilaginous wall would be absent, and you have to plan your grafts and your reconstruction accordingly. So because sometimes if there is not much septal support, you might have to consider harvesting the costal cartilage and reconstruct the septum. So this also has to be preoperatively discussed with the patient, an additional graft site possibility. So one must always palpate the nose very carefully. We all know about the Cottel's test and the Cottel maneuver. So just simply pulling the side walls of the nose, you find out the patency of the airway. Sometimes you can even use a nasal, the ear probe or any instrument, blunt instrument, to elevate the side walls and look for patency. So this will give you an idea if there is any collapse in the internal nasal wall or the external nasal wall, or it is due to a septal deflection that patient is facing breathing difficulties. A forceful inspiration. Observe the patient when the patient is taking a forceful inspiration, and observe for any external or any external nasal valve collapse. Also, as ENT surgeons, we are all equipped with an endoscopy setup. So one must do a nasal endoscopy to inspect the septum, look for any septal perforations, any turbinate hypertrophy, any polyps, any sinusitis, if there is any spur or deviation. And one must definitely correct, because a functional nose can never be, the functionality of the nose can never be ignored. Now at the end, so at the end, there is another additive we have another helping hand, which are in the form of these softwares, simulator softwares that are available. So basically what they do is they take the inputs of our pictures, and along with computer tools, they measure the various proportions and angles of the nose and help the surgeon to plan the surgery. This is a double-edged sword actually, because sometimes what happens is that they also have this option of simulating your rhinoplasty result. So once you show this to the patient might come back to you saying that you told me that this is the kind of result that is expected. So maybe you can use these softwares for your analysis to maybe convince the patient, but it can sometimes be dangerous as well. Next important tool is rhinomanometry. So these are two types of rhinomanometry that are there, active and passive, and acoustic rhinomanometry. So what happens is basically it is a study of the nasal pressure and the airflow. It is calculated from the nasal airflow and the transnasal pressure. A plot of dynamic relationships of the transnasal pressure and the flow on XY plotter shows a curvilinear relationship normally. Acoustic rhinomanometry is a much more easier thing. It consists of generating an acoustic impulse from a sound source which is transmitted along a tube. The sound, this pulse is reflected back from the inside of the nose, and according to the site of obstruction, the local acoustic impedance is studied, and one can measure the site of obstruction. That can be the nasal cavity, the nasal vestibule, the inferior turbinate, or the nasopharynx posteriorly. So once your full analysis is done, one must sit and define the deformities, what all deformities you can see on the front, the lateral, the base view, the sky view, and the oblique view. Next is formulate your thorough plan. This should be done before you operate each case. You should have a plan in your head. You should have a plan of how you're going to approach, open or closed, what kind of grafts you will need. Will you need an additional graft site, maybe a costal cartilage or the concha? What are the type of grafts? What all you will require? For example, spreader graft, extended spreader graft. What would be the length of those? This will all define the amount of graft material that will be required, and it will save you from a lot of intraoperative surprises. And of course, if there is any other reconstruction required, it has to be pre-planned. So for rhinoplasty, one needs a thorough art of observation. You need to develop an artistic eye. You have to analyze the face as the whole personality. Aesthetics and function go hand in hand, and ENT surgeons can very well achieve that, I believe. So that would be the end of this elaborate talk, and I would thank one and all for their patient listening. And in case you have doubts, please feel free to ask.
Thank you very much, ma'am. It is indeed very informative and vast and extensive also. And seeing this, I hope what I think is like every nose I see is having a need for getting the rhinoplasty done. Is there anything like ideal nose?
I don't think there is anything as ideal nose. No nose is ideal. There is always something or the other that but anything that doesn't grab a lot of attraction, I feel, is the ideal nose. If it is grabbing attention, that means there is something wrong. Usually beautiful noses never grab attention. The person looks beautiful. They will never say that your nose is very beautiful.
Yes, ma'am. Actually, the thing is like most of the noses, unless they are like very evident, we don't find any fault, or like we don't try to like try to the noses per se.
Yeah.
Seeing this lecture now, what I came to know is like every nose is having some kind of defect, and every nose is rhinoplasty. Like that, I'm feeling. That people can ask questions. Ma'am will be online for like few minutes from now, and they can ask questions, or if there are any like queries, they can go ahead. I'm unmuting everyone.
Good evening, Dr. Hina.
Good evening. Yes, sir. Good evening, sir.
I just have a question. Like, madam, how you would a 6-month proctorship or a fellowship, would you have more confidence undertaking more delicate procedures of aesthetic rhinoplasty rather than more deviated dorsums or hump nose deformities, where you'll have more confidence? Like, what is the time duration for the learning curve? Thank you.
So it of course it depends on your own potential and all those things, but it is a long learning curve, and I am still learning. I practice exclusively rhinoplasty, and still I sometimes stop myself from doing complex cases and these fine pure aesthetic cases, because it definitely takes years and years of practice to select the kind of patients that you want to do. But of course, deviated noses, saddle noses, and reduction rhinoplasties, these are much one should start their practice with all these kind of gross deformities first, and once you're confident with your own results, probably you've seen your results for over 2-3 years, and you feel that what you're doing is right and your patients are very happy, then maybe you can go on to these finer cosmetic rhinoplasties. But it ultimately is you, and mere observation will definitely get you through the basics. But then these finer things will you and your patients have will go through that learning curve. Hello? Hello?
Hello, ma'am, can you hear me?
Yes, I can hear you.
I think
I hope Dr. Satya could hear my answer.
1 minute, 1 minute. I'll try to unmute, sir. Send
Yeah,
the request. Sir, Satyanarayana, sir, you can speak now.
thank you, Dr. Hina. I was muted. That was a good answer. Roughly, like what is the duration? I've been doing very regularly, a very few number of cases. Over past 10 years, I've been associated with some plastic surgeons, but nothing.
Yes,
I've only been learning through rhinoplasty through through your lectures, or Dr. Kshitij, Dr. Gassias, Dr. Basar.
Yes, sir.
They have been all teachers here, really, and it has been of great understanding. But still, to embark on these delicate procedures, I still find myself nervous, when
Even I do, sir.
Yeah, thanks much. Thank you, doctor.
Yes, sir. Yes, sir.
How to deal with the medical legal aspects of this rhinoplasty? Like, is there anything to be done before going for
So
surgery?
the first step to avoid all these medical legal problems is your patient selection. So that is why I pay so much of attention on these psychological aspects and studying the body language, because once you land up with a problem patient, it's just it's a big problem. So probably I in my practice I refuse around 20 to 30% of the patients that come for rhinoplasty. So patient selection is the most important thing, especially in the start of your career. I would suggest that you should make sure that you have a foolproof patient series, and you should be confident through multiple consultations. The patient should never be unaccompanied. Talk to the relatives, talk to the patient thoroughly, discuss what you can give and what you cannot, and that is how you will probably skip any medical legal problem. But even then, your consent form for rhinoplasty has to be very thorough. It should mention all the possible complications and all the possible sequelae that you feel. And especially if you're planning a graft from another site, you have to discuss, and you have to note it down that you are taking an additional graft, probably from the ear, or from the rib or somewhere. So if you do so, and then of course your rapport with the patient, if it is thorough and there is a clear understanding, then it is highly unlikely that you will lead into a medical legal problem.
Dr. Hina, can you please tell us the name of the software? I think it is available for free online.
The one that I showed the picture?
Yes, ma'am.
So there is one called the Plastic Surgery Simulator.
Okay.
which is a mobile app. It's a simple mobile app.
Okay.
So that can give a slight idea about the results. Probably some augmentation or reduction can be performed on that, and you can show the patient. But as far as these measuring the nasal proportion measurements and all these angles have to be measured, these are very complex softwares, and they are very expensive as well. So I know of a few. One is the Dolphin, and the other one is, I think, the it's just slipping my mind right now. But there are a few from Korea and Germany.
Okay, the one you said is plastic surgery. So
Simulator app.
Okay.
Yeah.
Okay. Actually, no, I just wanted to ask one question. There's a depth analysis feature on some of the smartphones, especially I think Apple. Does it have any apps that have been created for this Apple software, Apple OS, that use this depth analysis, because that gives you a more accurate measurements, I think. Have you come across anything?
I haven't come across yet. I'm still an Android user, but I'll definitely explore now that you've mentioned.
Yes, ma'am. Thank you so much, Dr.
Thank you, sir. Thank you so much.
Participants can ask questions if there are any queries. They can ask directly.
Dr. Hina, can I ask a question?
Yes, sir,
suppose you said we can use conchal cartilage. Dr. Vishnu Reddy from Hyderabad, he tends to use a lot of conchal cartilage. But every time we harvest conchal cartilage, and sometimes he uses this sandwiching of these conchal cartilages, layering them and suturing them, and then using them for the graft. But is there any age criteria in which beyond a certain age, the conchal cartilage will tend to break down, will be more what you call calcified or more brittle and get damaged easily? Because not always you will get a supple conchal cartilage. In younger people and women, you tend to have a supple conchal cartilage. What is your take on that?
So I think, sir, you're talking about costal cartilage, not conchal.
No, ma'am. They use conchal cartilage.
So conchal it is very rare that you would find any kind of calcification in the conchal cartilage, and usually we are very lucky with it. But the only problem is that the strength cannot be relied on. So if you need a strong skeletal reconstruction, for example, if you are looking at a severely depressed nose, whereas you are reconstructing the K-junction area, and you're doing an entire septal reconstruction, maybe conchal cartilage is not the ideal graft material for that. A costal cartilage would be a much better option. Conchal cartilage, in my practice, I use it for minor camouflaging, probably small suppurative depression or something. I need a small amount of cartilage. I use that. Maybe if I need some kind of a curved graft material for the tip, or maybe for the alar rim, I would go in for a conchal cartilage. But I'm very comfortable with the costal cartilage.
Okay. Do you harvest the costal cartilage yourself, or you take the assistance?
I do it myself so far. I've been trying to train my husband. He's also an ENT surgeon, but he's not available most of the time, so I end up doing it myself.
Okay, that's nice. And do you, when you
it definitely increases the surgical time, and it becomes tiring as well. But my team, my assistant has become a little proficient in the closure and all those things, so it saves a bit of time.
And you take the 6th to 7th costal cartilage?
I prefer the 9th, actually. I take the 9th, and if required, the 8th maybe, because it's much more straighter there.
Okay. But you can go all the way from 6th to 9th, no?
Yeah, that requires a little higher incision. What I do is I just palpate the subcostal angle, which corresponds to the 7th, and then the costal angle, and it corresponds to the 7th. I also palpate the subcostal angle, which is roughly the 9th and the 10th, and in between somewhere I give the incision so I can access the 8th as well as the 9th.
Okay, thank you so much. You anchor it with sutures to the key area, or you just how do you?
In case of a septal reconstruction, you're saying, sir?
Yes, yes, ma'am. Septal reconstruction with keystone reconstruction.
Yeah, so it all depends. If I have a stump of cartilage there at the key junction area, I try to take a figure of it suture with the new septal extension graft and the remnant septum. If there is no septum there, not even a stump, then definitely I anchor it to the nasal bones. I drill a small hole in them, transfixing suture is taken, and I usually do it with a permanent suture.
So what is the size of the drill bit, ma'am? It is 0.5, 0.6 like that?
Sorry?
Into the nasal, the drill hole in the nasal bone. What is the size?
So I have this Lindemann burr, which is also used by the dental people. Yeah, yeah. Okay. So that is what I use. It is, I think, 0.4 millimeters.
Okay, okay. Thanks so much. It doesn't break or anything.
It is also available
right?
with the Smith & Nephew guys also.
It doesn't break or anything, no?
It doesn't. It doesn't. If you buy, if you buy the cheaper ones, it breaks. It has happened with me twice.
No, I don't mean the drill bit. I mean the nasal bone. It doesn't crack.
Okay. No, it doesn't break. It doesn't break. But the drill bit has definitely broken twice, and it has given me a tough time twice. I remember it very clearly.
Thank you so much, doctor.
Yeah, yeah. Thank you.
Right, participants can ask any queries or questions. We have a few more minutes before we close the session. Seems like no questions are there in the chat box also, ma'am. Like,
okay, no problem.
Right, ma'am. And
all right, thank you so much. It was nice interacting with Satyanarayan sir.
Thank you so much, ma'am. I'm going to trouble you with some questions when I get the case doubt with the case.
Sure, sir. My phone number and email are there anytime,
yes,
sir. No problem.
Definitely. Thank you so much.
Yes, sir.
Nice,
Yes, sir.
nice
Thank you, everyone. Thank you, Kishore.
Thank you, ma'am. We'll meet next week with next topic, that is dealing with the deviatinosis.
Sure, sure. Right. Thank you so much.
Thank you, ma'am. Thank you, Anand.
Looking forward. Bye-bye.